The broadcast is now starting. All attendees are in listen-only mode.
Well, welcome everyone. I hope everyone's having a great evening out there. How you doing tonight, Rich?
I'm doing well, thank you. How you holding up? You know,
Good.
you've been teaching a lot and talking a lot, so traveling all over the country. How you holding
Yeah,
up?
good. So my voice is a little hoarse from teaching at the Pankey Institute for 5 days. Actually, went through this medical billing there earlier this morning, so it's fresh on my mind. So
Oh, good.
hopefully we'll get through it right again. We have a lot of people signed up tonight, several hundred. So we've got your mics muted because we can't open them up to that many, but we're happy to answer your questions. So we have our whole four-pillar billing team on answering questions. We'll answer the questions. So type them in the question box as we get going, and we'll be happy to try to get to all of them before the night's over. So, you know, Rich, none of this makes me nervous anymore, and we don't do a whole lot of it, but root canals, crowns, all these things, I think dentists out there, they see this, and you know, nothing really bothers them about this because it's what they're used to doing every day in their offices. But if they had to fly their own plane to California, where I'm going tomorrow, or be their own judge, or do their taxes themselves, or if they get audited, be their own CPA, I think it'd make them nervous. And you know why that is? It's because they don't do that every day. You know, we do the dentistry every day and we're comfortable with it, but we don't do these things every day. And even if you know how to do a little bit of plumbing, you're gonna bust up your knuckles and not have the right things. And I want to just make something clear. We're going to teach you a lot about what we know about it, how to do these things. But if you think because you've got a dental team member that does dental billing in your office, you think that they're going to be able to take care of this medical billing, you're wrong. You can't do medical billing just because you do these other things. And much like just because you know how to do a root canal, you can't fly your plane. It's just as different as that when it comes to medical billing. It's a tough
It's
difference.
just different, isn't it, Guy? It's not that that person can't learn how to do it, and that's part of what tonight's about. Is that we're certainly, you know, want to help you guys learn how to do this.
And the good news is, we say this a lot, that you don't know how good you all have this at times. 6-7 years ago, you really had no choice but to figure it out yourself. Now there's many companies out there that specialize in medical billing for dental sleep medicine, including four-pillar billing, which we'll talk about. But we regardless of which company you're using or going to use, work with them at least until you get busy enough to go out on your own. You still need to know a lot to do it, even with these third-party billing companies. So that's what we're going to go through this evening.
Yeah, I'm sure that's how my staff reacts, Guy. When I used to go to a, you know, I remember one of my staff members didn't know I was around the corner, and it's like, what course did Dr. Drake take this weekend? What do we have to start selling now? You know, it was kind of one of those kind of things. So, you know, we certainly want you to bring your staff to the courses and that, because we always talk about how many questions are asked at a dental office every day. There's 100, but only 5 or 6 are asked to the dentist. So there are a lot of questions being asked, and you know, you're getting your team involved, Guy. We do whole webinars on that, but that's probably one of the single most important things that as a dentist we can do, other than understand how to get paid, of course.
Yeah, and just because you're going to work with a third-party biller doesn't mean you wash your hands of all this. You have to do certain things. You still have to interact with your patients. And what we're trying to do is take this insurance load, the heavy lifting part of this, the part that involves actually interacting with the insurance companies and doing the actual billing and making sure all the documentation's there. That's what the third-party biller should be doing. You still need to be working with your team. So we talk about the 4 pillars a lot. I know a lot of our webinars are well attended. It's because we try to break this down. The last thing I said to this group of dentists today before I left, Rich, was go back to your offices, start doing this. But in 6-8 weeks, if you're not doing the dental sleep that you thought you'd be doing, look at this slide right here. Because if you have systems in place, team members in place who are willing to do this and trained to screen, test, treat, and bill your patients, you're going to be as busy as you want. There's something going to be missing in there today. Well, we can't go through all those pillars today, but we are going to concentrate on billing.
Yeah, and you got to remember you're crossing a line here. Guy was just talking about your staff member and they're trained how to do dental billing and stuff like that, but we're not. It's kind of weird, Guy, because we have a dental solution that little piece of plastic we put in their mouth, for a medical problem and a medical diagnosis. So we have to remember that we live on that side of medicine in this particular instance. Dental insurance does not cover this. They don't cover any of this. So we have to remember that we're crossing that line when we think about treating these patients.
Yeah, so the moment you treat a patient who's diagnosed with sleep apnea with a dental device, you're doing a medical procedure. And I think you have to put on your medical hat. And many of you probably haven't thought about the differences between dentistry and medicine, in particular when it comes to billing. In dentistry, if you want to do a DO composite, you just submit the DO composite. You don't have to have a diagnosis code of distal decay to go along with that. In medicine, every procedure you do, you have a billable code, the procedure code rather, and then it has to be actually tied and linked to the diagnosis code. In this case, obstructive sleep apnea G47.33 is the code. But without those two, you can't get paid. You only need the one in dentistry. And Rich, it's been a little while since you've submitted a dental claim, but if you wanted to do a crown on a patient, what do they usually?
Me, Guy. That would really scare me. It should scare my patient.
Not as much as it would scare the patient, I'm sure, but if you want to do this and you want to make the diagnosis, well, you can do that because you're the dentist. But when it comes to sleep, we can't make those diagnoses. We have to work with physicians. We have to get a diagnosis, ideally from a board certified sleep physician. So if they want to know if this procedure is covered, what do we always do in dentistry?
We do that crown.
Yeah, we send in that x-ray. They've got some dentist there that, is retired from dentistry or whatever reason. He's sitting around in an insurance office. We can talk about that for a while if we want, but we won't. But he's going to look at that x-ray and say, he or she's going to look at that x-ray and say, well, yeah, if I see the decay, I see the crack. Yeah, Mrs. Jones, you can have that crown on it. And they determine it from that x-ray. And in medicine, the determination of whether it's covered is primarily based on paperwork, on your documentation, and particularly your proof of delivery, your chart notes, and a lot of things we're going to go through on here. I don't know if I've ever heard of in dentistry them coming back and looking at this later. My experience was you had to fight them up front to get the money at the time you sent that pre-authorization. Is that what you recall, Rich, when you were doing?
Absolutely. And once you got it, it was yours. So
it was yours.
Yeah, it's not like that in medicine. So I've already been audited, once this year, Guy, already. And last year we got audited by a different insurance company. And again, I'm not trying to scare you off, but they can ask for their money back. If you don't have that diagnosis code, if you don't have that, show the medical necessity through both your documentation as well as the previous doctors that have seen them and that kind of thing, they can say, you know what, you don't have all this stuff. We want our money back. So again, that's not to scare you. We want to teach you how to do this right. So even if they do all of that, you just have everything all the time ready. So you're always covered. It's not that big a deal when we get audited in my office now, Guy, because we know we have everything.
For the record, audit went well. They didn't ask for any money back because you did things the right way. And I think the take-home medicine there is dentistry. They try to keep you from getting the money. In medicine, they give it to you, and then they come back and try to take it back later if you're not, if you haven't done anything right. And so they both have their own bumps, but just realize it's different. So if you start billing this and think you're home free, if you're not doing things correctly, it could come back and get you later. And in dentistry, I go ahead.
The other thing I want to add, Guy, is the pre-authorization is often required. And the difference in medicine is if you don't pre-authorize it, they just don't pay for it, period. It's not like, you're just saying, hey, they might pay for this or they might not. So again, we'll get into later about how you verify benefits and instant eligibility and all these types of things. But you got to remember, that's a real important piece of information that you have to remember.
Yeah, and let's talk about that for a second, because the pre-authorization in dentistry is different than the pre-authorization in medicine. Today, when I was teaching this, it really took a little while for them to understand. In dentistry, we pre-authorize the fee, not the procedure. Well, the main reason we do that is to see, do you cover it and how much you're going to pay me. In medicine, especially if you're out of network, they're not going to tell you how much they're going to pay you, but it's just a step that you have to do if you're going to get a procedure done. A lot of times the primary care has to say this is necessary, and then they if it's not an emergency procedure, they want you to check with them first and make sure that it's covered. And so you're right, it's almost always required, especially if you're out of network. And then the chart notes, Rich, I think that's probably why your audits went well. If you go into a dental office and you look at their last procedure, it'll probably say something like patient came in for DO composite, what material you use, what anesthetic you use. It doesn't have all the chart notes that you need, the chart notes from physicians, the history of present illness, all the kind of things that we might want to put in a SOAP note. And some of you were likely taught SOAP notes in dental school, but I know from talking to dentists all across the country, they don't typically use them anymore. And so you want to put it in that medical documentation format from subjective, objective, assessment and plan. And then
so
furthermore,
everything you're talking about, guys, changing from how we do it in dentistry to how we do it in medicine. That's why we drew that line for you.
Yes, it is. And I don't know that we have a slide about this, but we also recommend that you keep a separate chart for your dental sleep patients while you're for medical billing and just for legal reasons as well, because all this is so different. Even if you're using paper charts, have just a different colored folder to say this is my medical chart for the medical procedure, and then I do all the dentistry over here so it doesn't confuse anybody. And last thing on there that we haven't touched on, Rich, is the form that you submit it on is different. This the ADA form versus the HCFA form, and depending on your dental software, you very well may not even be able to utilize a 1500 form with a lot of the softwares, and so you're going to have to find a way to submit that. So I think this first slides here show how different it is, and that's one of the reasons we need to walk you through this.
Yeah, well, if that didn't knock your socks off a little bit, you know, we have to talk about how we bill for this and what we expect to be paid. So, you know, I think this is a hard thing for a lot of dentists to get over too, Guy. You know, I've been doing this for 20 years myself now, and you've been doing it for almost that long. So, you know, in dental, we charge you $1,000 for the crown or whatever it is, and that's what we tell the insurance company we're going to do, and that's what we do. Anything other than that, right, doesn't seem right. And in medicine, write-offs are part of the norm in what we do, and we can write off some of that stuff.
Yeah, and even if you go to the ADA Code of Ethics, it basically, and I'll just paraphrase this so I don't just read you the slide. Basically, they say if you accept a co-payment from an insurance company, so you do a crown and it's $1,000 or whatever the procedure is, and they pay $800. If you just accept that and routinely write off the other $200 or the patient's copay, well, that's overbilling according to the ADA. I think most everybody on this webinar feels comfortable with that statement. Now, if we look at the Medical Society's Code of Ethics, it's almost 180 degrees difference. It says that patients are made more conscientious of these costs through their copayments, but if for some reason that copayment is a barrier to them getting their needed care, then you should write off that difference for the patient. In other words, it's unethical to not do that, because I think what it comes down to is maybe a DO composite's not as life-threatening and oftentimes as some of these medical procedures. It's just the way it is. Don't shoot the messenger. Rich and I didn't develop this system. You know, they
didn't ask us to write the code of ethics, that's for sure.
No,
yeah.
No. So it's the way it is. So you got to think about all this, just a little bit of difference. But I think this is probably the take-home message. Rich, how often you talk to physicians or patients? Is this what it comes down to?
I did 10 new patient consults today in my office, Guy. Wow. And 9 of the 10 asked these 2 questions. How much does it cost and what will my insurance cover? And that's a little off. Usually it would be 10 out of 10, you know? So my staff had actually done a really good job on the 10th one, and he already knew. So that's why he didn't ask. He'd already asked the question. But you know, every time somebody sits down, you know, they're gonna have 3 questions. I hear all the time. Am I a good candidate for this, or is it gonna work for me? How much does it cost, and what does my insurance cover? So you have to have a plan. If you don't have a plan, well, I don't know. I mean, we could try to figure that out, or, you know, we're not in network, or we're in network, or Medicare, or what do we do here? So that's why you're here tonight, so we can talk about some of this stuff.
Yeah, and you know, one of the options we're going to give you is that you cannot mess with medical insurance. And I mean, why are you listening to a medical insurance webinar tonight if you're not going to deal with it? Well, maybe after listening to this, you're going to say, you know what? I just want to treat my patients in my office. I've got a fee-for-service office. I'm just going to just do it and tell them to go deal with insurance on their own, or maybe I'll do it and file it for them, but tell them you may get nothing back. I can't guarantee anything. And that'll work. That works well for the offices that are used to doing fee-for-service payments. But what it won't work for, what it will never, ever, never, ever, never accomplish is getting a broad base of referrals from the medical community, sending patients to your office, because the first thing they're going to ask you when you talk to a physician about working with them is, do you deal with medical insurance? And if your answer is no, we just charge fee for service and hope they get some coverage elsewhere, they're just not going to refer your patients. And you don't have to have that to make this procedure worthwhile in your office, because a lot of your patients of record need this and they're wanting to pay.
Every day.
Yeah, but just understand, if this is your goal, then you need to pay close attention to the rest of this and find ways to do it, because you're not going to get those medical referrals if you don't manage insurance properly. It's mandatory. We do these webinars all the time, every other week, and hey, Rich, we get a week off.
Hallelujah.
Hallelujah. Now this is going to be a good one. Dental sleep marketing is coming up. We'll put that up at the end. With Jason Tierney, our COO, he's as knowledgeable as anybody is in the whole sleep world. They're going to be talking about with Mark Fowler. I've met him multiple times. He's very knowledgeable about marketing, in particular digital marketing. If you want to bring your dental sleep practice to the next level through marketing and digital and external marketing, they're going to teach you about that. So this is a subject we haven't done a lot on in the past. So mark your calendars. It'll be May 15th at the same time, 8 o'clock. And you will get credit if you stay on for the full hour. And we will send you an email in the next 72 hours. If you don't get that, please check your spam filter, because it will be in there, and you'll get the credit for being on tonight's webinar. I think we've already introduced ourselves. Yes.
Yeah, I'm the guy with less hair on the one side there. Like I said, Guy and I have been doing this a long time. We met a long time ago, and it's been a journey, because we do what we do to help dentists succeed at dental sleep medicine in this, and we started that a long time ago, Guy, and we're actually starting to move the needle in the entire country now. By what we do and how many people we help.
It makes me want to get up in the morning, even though I'm tired most days, because we all work too many hours. But you're right. And, I think we oftentimes, people ask what we do, and I think we just put this slide together. We help you bring all this together. So we have a 360 solution for helping dentists who want to implement the dentist sleep in their practice, from software to training to insurance help. So if you're interested in learning more, type in consult sometime throughout the night. We can actually tell you how we can help you, but we'll also answer some questions. A lot of people may just have one or two questions that we don't get to that's not related to the night subject, and we have dental sleep medicine trainers that are going to be happy to sit down with you and talk about your needs with no kinds of pressure or anything like that. It'll be very helpful. If you type that in, you can get a free consultation tonight. Just type it into the question box. This is the way we help through education, coaching, software, and support. We'll talk a little bit more about that in a little bit, but before we go into one more thing I want to talk about, Rich, is this Dental Sleep Medicine Insider. This is free, so we're not asking anything from you. I just want to make sure that you all know that it's out there. I had several people in my continuum this last 3 or 4 days tell me that a lot of the articles in there have been very beneficial. We have all kinds of guest writers. This comes out about every other month. The next issue is coming out in a couple of weeks. I think May 15th, 18th, something like that. So go ahead and just sign up. It's free. It'll come to your inbox, and you can review all the past articles. Some questions that came up during our 4 days, 5 days at the Pank is, what happens when you run out of room on your dorsal device or something like that? Well, there's a video in there in the past issues for that. Rich has all kinds of great articles he writes. Then we have all kinds of other outside contributors. So go ahead and sign up for that. It's free, and I promise you, if you want to learn more about dental sleep medicine.
Something out of dental sleep, absolutely.
All right, want to get down to a little bit more nuts and bolts. We'll talk about making some money on dental sleep and establishing our fee. I think the first thing we need to do, Rich, the first question people ask me when I teach a course on
how much do you charge for this, Guy?
Yes, and you know what? And what I say is, how much do you want to make? And that's really what you have to think about, is how much do you need to get paid for each patient that comes through the door and they do a dental sleep device to make you say, yeah, I want to keep doing this. Because if you don't make as much money as you do doing other procedures, you're not going to do it because you got to pay your bills. So you've got to figure that out. So I can't tell you how much you need to make on this or what the charge until you understand that. So I would ask you to go back and look at your office overhead and to figure this out. Well, maybe that's going to be too complicated. So we just have a system here where you can go back and do this and at your leisure and just pick a procedure like a crown or root canal, dentures, whatever you like to do, and say, let's figure out how much of your doctor time and assistant time it takes to do that, back out any lab bill, and then you can figure out how much you're charging per hour of doctor time for that procedure or assistant time. So what would be a good, I don't know how much crown is. So I do know how much crown is. I had to pay someone to do one on my wife recently. So I think it was a little more than this, but that's okay. We'll use this scenario here. So the numbers aren't important here. It's just the idea. $1,300 crown. I don't know. $300 for a lab bill is probably pretty high these days with all the competition in that area. But let's say that's what it is. So that's $1,000 what you get after the lab bill. What happens after that? Well, if it took you an hour.
How long does it take?
Yeah, when I did the crowns, it took me an hour. Whether I did a CEREC or whether I did a two-step, it took 45 minutes to prep and 15 minutes to seat it. So it's an hour. If it takes you 2 hours, plug that in. Chair time, it takes us about 2 hours when I was doing the crowns in my office. So you can figure out how much it is per hour of time. Now, what you don't know is how much dental sleep. And so we threw some numbers here for, and they're very conservative numbers. If you get good at this, you can certainly cut this time down. We have an hour for doctor time, and I tell most everybody who uses our DS3 system, if you'll use the system, you can get that well less than an hour, but the minimal 45 minutes of doctor time. But let's be conservative. Plug the hour in there, so it'd be $1,000 was what you would need. But you might want to look at assistant time because assistants do more of this if you do. Auxiliaries do more of this if you do it appropriately, and you might want to look at it that way. Or what I just say, just average those two together, and you can look at the math there. When you average those two together, and this scenario is coming out to be around $1,500 you would need if that was what your crown fee was for this amount of time. So do your own math. But what I want to say is, there's a lot of people in the country going, oh, you can get $6,000 for these. You can get $9,000. Yeah, you don't need that to make you happy to do this. Rich, I've done this when I do a lot of the courses, and I ask the people to do the math. And at the end of the day, most of them come between $1,500, even a little lower than that, some of them, and no more than $3,000. But I would say the average is around $1,500 to $2,500 that people need to make per case to make as much money as their highest paying procedure in their office. And that's right within the ballpark of what's readily available to get for these devices. You don't need $3,000, $4,000. If you get it, good for you. But don't think you have to have that to make you happy to do this.
Very well put, Guy. That's a good exercise for, I think, all of us as dentists to go through occasionally and just reevaluate what we're charging and how we're doing, because sometimes materials change and things change, Guy, and we can be more efficient at some things. And I think we owe it to our patients to provide consistently good, competent work in a reasonable manner. We've always said, keep the patient's best interest at heart, and you never get too far, off the system. So out of the way, but we got to decide medical or dental. I think we've already made that clear that we're going to be billing medical. So we're going to talk now about a couple of different ways to do this. You got to make a decision with Medicare, how you're going to deal with that. And then some of you are in network with a dental plan. Well, we have to look at that the same way with the medical plan. I am in network with 5 different insurers now, Guy, wow. and we can talk about why that's advantageous sometimes and why it's not other times. And then lastly, we'll talk about, how you bill for this, because remember that patient's going to ask those questions, Guy. How much does this cost and what will my insurance cover? And so we got to have a way to bill those people for that. But it all starts long before you sit down and talk to the patient. You have to remember that.
Yeah, absolutely. And by the way, I checked, some people are typing some questions in. We're getting to those answers, so keep them coming. We'll make sure we get to all of them. We'll answer them as we go before the night's over. Yeah, before we can bill an insurance, we need to talk to our patients first and decide if they're a good candidate. Whether forget the billing for a moment, we need to decide, is this a good treatment for them? And so before they ever come in for the consultation, one thing that's almost my mantra is we've got to have a copy of their baseline sleep study. We've got to have a questionnaire to kind of ascertain as to what their driving motivation is. Is it sleepiness, snoring? What other treatments have they tried, CPAP and so forth? And then we need to know, if everything goes well in the consultation, when they say, hey, yes, I'd like to do this, how much is it? We need to know how to answer that question. Now, you can find out the benefits by calling the insurance company, and that may take you anywhere from 10 minutes to an hour to find out what if they have coverage and what their in and out of network benefits are, and what their deductibles are for in and out of network, and what their percentages they pay. Or there's some ways you can do that with an instant eligibility check. Through our DS3 system, you can do that with a click of a button, and we know instantaneously there what their benefits are and what their coverages are. Now, we don't always know their allowable amount if you're out of network, but we certainly have ways of taking that information from instant eligibility check and saying, yes, here's how much it's going to cost you in the worst case scenario, what we call our maximum out of pocket, or something I nicknamed the MOP. Here's what your instant eligibility check might look like. A lot of information there, but once you learn how to read it, you realize you have all the information at your fingertips to go ahead and estimate the patient's portion, if that's the way you choose to do it. So we've got a sleep study that filled out a questionnaire. We verified that they have insurance. What else do we need, Rich? Quite a few things, right?
Well, we're getting started anyway. That's a good start on it. Remember, we talked about the sleep study. Sometimes they have to have certain requirements have to be met. We'll talk about those when we get to the Medicare thing. But, we have to have a physician prescribe this, and it has to be documented that it's medically necessary. That's where you really, really have to learn how to work with physicians in this matter. We're not here to debate whether or not that's the way it should be, or, nothing like that. We're just telling you how it is. I get paid pretty much every time, Guy. And that's because I have all of those things on the left side of that. Every single time we have all of that stuff. So the proof of delivery, it's just a simple, you can contact us. We'll show you what that is. It's just a simple piece of paper that we have the patient sign. But you certainly have to have a way to submit claims as well. We know how to do that through dental. Some of us might need a little help with that on the medical side.
Yeah, so let me talk about a couple more of those. I think this is an important slide. This is all readily obtainable information, but it's not just going to pop out at you. You've got to make sure that you get a copy of it. So when you get a copy of the sleep test, oftentimes that's coming from the primary care or sleep physician. At that time, you can ask them for a copy of the clinical notes, or a lot of times they supply it anyway. Basically, it tells why the indications for the sleep test. Why did they have a sleep test to start with? And Medicare requires that you have that. Some of the other insurers do. So when you're getting a copy of sleep test, just ask for that as well. And it's usually, like I said, most of the times they include it if you don't ask. The CPAP intolerance, I don't think you mentioned yet, Rich. For Medicare, we'll get to that in a little bit. But what I think we're going to get to, we didn't go too far deep into Medicare as we do sometimes. If you go by Medicare standards for all your patients, when it comes whether they have Medicare or not, you're going to be pretty much safe across the board. So Medicare and many insurances say that people who have severe apnea have to try CPAP first. And if that's the case, then you need to document that they tried it first. And that's what that CPAP affidavit just says. They tried it and why they couldn't wear it. And that information is also quite valuable in deciding on the treatment for the patient, whether they're going to do combination therapy or which device you might do. There's some reasons why that information is important as well. Rich mentioned that this documentation, but let me just explain what that LOMN is. That's letter of medical necessity and prescription. What that is that's a letter that says that this patient, it usually comes from, what do you call it, Rich? The best doctor. Primary care is what we usually say.
Yeah, that's what we call it.
Yeah, the best of who do they see the most? Some of the patients here in Florida, their best MDs are cardiologists or something because they're there every day, or they're pulmonologists that have got COPD. So who are they seeing the most? Who's their best MD? We send this to them with a request. Make it all easy. We can fill it all out, so they only have to do is sign it. But it basically says that the patient has apnea and it's medically necessary for them to treat it, and then they actually have a prescription for the dental device, E0486, and we actually supply the physicians with that many times, all laid out for them. So all they have to do is review it and sign it and send it back, so they don't have to write all that out. And one last thing I want to mention here too is the proof of delivery. That's the day we deliver the device. It's just something the patient signs. This is durable medical equipment. My mother got oxygen because she's has COPD. She had to sign a piece of paper saying, I received the oxygen. They treat us the same way. While I'm talking about that, it's really critical to know that we should not ever, ever, never bill the insurance company until we deliver the device. Most of you dentists are used to cutting a crown prep and sending off the claim because I've done the crown prep. Not that way in dental sleep medicine. You wait till they sign that proof of delivery, and that's the day they signed it is the day that you submit the claim if you want to stay out of trouble. So pre-authorization, Rich, we already talked about. We've kind of had an argument about that. I think you thought I should put that over here on this side of the column at one point. Yeah.
Well, and we've had a couple questions there, Guy, about that, and Lisa, our insurance manager, is really doing a great job answering these questions, Guy. But you really, until somebody in your office picks up the phone and calls to verify that, we don't know if we need that or not. So I will tell you that over the last 5 years, we're seeing it more and more that we're needing it. So it's not that we want to argue about that. We just want to know if we need it or not, because it's a deal killer, so to speak. You know, if you come see me, Guy, and I say, man, I got everything I need, let's go ahead and do this. So we take your scans and your bite, and you come back in 3 weeks, and I deliver the device, and now we can file the insurance. I have everything on that left-hand side, but your policy requires it to be pre-authorized. They won't pay for it now. So you're not happy. I'm not happy. You know, now all of the numbers don't make sense because we were counting on getting $2,000 from the insurance company, and now we're not going to get anything. So you got to find out if you need it or not.
And I agree that most cases you do these days. So just count on getting it. And if you make the call, and again, this is a third-party biller insurance company will do this for you. They'll find out, and if they say, hey, good deal, we don't have to have one on this case, then you're up and running. But just plan on it because you're going to need it most times. So let's talk about Medicare, Rich. We want to clarify that Medicare and commercial insurances are total different entities, totally different animals. So we're going to talk about Medicare first. And almost every time I talk about this, it's hard to judge what's going on out there in your homes right now. But when I say Medicare, they're, you get this. I don't want to talk about Medicare. Everybody's afraid of Medicare. It's almost a bad word. Do you get that when you talk to people about it?
Oh, I would say everybody who's certainly under 65, you know, those of us who are 65 or older don't feel that way because, you know, we want, you know, I read something the other day, Guy said in the United States, 10,000 people a day are turning 65 years old. I don't, you know, it's on the internet. It must be true. I didn't verify that fact, but at any point it is a lot of people. And I think the reason that as dentists we get scared away from that, Guy, is because we know they have a very strict set of rules. And if we don't follow those rules, then, you know, like the Medicare police are going to show up and put us in handcuffs or something. That's not true. They might ask for their money back. But, you know, I love treating most of these patients, Guy. They're respectful. They like what I do. They appreciate what I do. Most of them seek me out because they're looking for someone who's knowledgeable in this and what they're doing. So there's certainly a lot of reasons to do this. And it's not always old people. You can be younger and just be disabled and things like that. But remember, this is not Medicaid. You know, Medicaid is different than Medicare. So we're talking about, you know, the insurance that hopefully will be there when you and I turn 65, Guy. But at any point, it has a set of rules. So you got to figure out what you're going to do. It is a global fee with Medicare, the E0486. That is the treatment code that we use for a custom fabricated oral appliance to prevent the collapsibility of the upper airway. And an LCD is a local coverage determination. So we've got a couple of slides in there, Guy, that you guys put together that are fantastic, where we look at the different regions and what they pay. But like other insurance companies, Guy, Medicare in a region has an allowable fee, and then we know what they're going to pay. when we do this. So we can actually give the patient a very good idea about what their out-of-pocket is if we want to participate or non-participate. So I know I'm getting ahead of myself there, but we're going to talk about that.
Yeah, and but to be clear, most people have this a secondary it's actually supplemental insurance. I have a typo in there. It's not secondary, supplemental insurance, and so most people have that who's going to pay that 20%. So it's pretty much across the country. So here's the allowable amounts, pretty much to the dollar. Understand these can vary a little bit per region. They have the right, if you want to call it that, to change these per case. We don't see that very often, but as I spend time in the 4-pillar billing office and I talk to them, they say on occasion we get a few dollars that are lower or higher than this in these areas, but you can pretty much count on them being within a few dollars to this. So if you live up in the golden states, as I will call them, because it's the highest reimbursement area, in our class this weekend, we had a couple people up there. I've threatened to come move in with them to get this kind of coverage. So this is the highest area. The allowable amount's $1,800. I mean, you do that math that we talked about at the beginning of this, I promise you that's pretty close to being in the ballpark of what you need to make you happy as you are doing all your other procedures in your office. We're going to talk about some other ways of doing this in a minute, but that's the allowable amount. The 20% is the $363, and the 80% that the Medicare pays is roughly the $1,422. And again, that $363 is typically paid by supplemental insurance. If they don't have supplemental insurance, which just happens occasionally, then that's the patient's responsibility. So we'll go through the other areas. I'll leave them up for a few moments so you can take a picture of it or something, or write it down for your particular region. This jurisdiction B is still up there above where Rich and I live. We'll get to that in a minute, but up to 1354, and you can see the breakdown. And then here we are in the wonderful region that Rich and I live in. He lives in Texas, I live in Florida, and we certainly got the lower part of that deal. But I don't, and people ask today, why is that? And I said, if I only knew, I'd talk to whoever made these decisions, because my cost of living is as much as many of these people in these other regions. So I don't know. They're independently run. It's the government. Don't ask me to explain the government to you. We don't have enough time for that. So nor do I have the expertise. But 1,070 is our area, and then over here is around 1,369 as well. So you know, they all contribute something, and we're going to talk to you about how you go about doing this. So don't turn off the computer right now if you live down in Florida or Texas or in one of those states, because we're going to show you how you can still make a decent living from these Medicare patients. You got some choices here. Like our slide with the choices here, Rich?
I like that. You know, you got to go which way you're going to go. So you got to choose. You know, you don't have an option here. You got to do something. So, you know, first of all, you need to become a Medicare DME supplier. So we have another slide there, but I want to get that out right now. So we'll talk about that in a second, how you do that. It's an application process that any biller can help you out with. But, you know, you can opt out, or you can be a Medicare provider. Okay, you can participate or non-participate in as a provider. So we're going to talk about each one of these three. So with the opt-out, you got to remember, you are signing a contract with Medicare that you will not bill Medicare, nor can a patient you treat bill Medicare. So you got to remember, you are out of the system. You're not going to deal with this at all. It's a 2-year contract, and you have to have the patient sign this advanced beneficiary notice. And the best way I can describe that, guy, is if I'm a Medicare patient and I come to see you and you've opted out, you might tell me in a very deceptive way that Medicare might pay for some of this. Your part's $1,500 or whatever. And I think I'm going to get reimbursed some of that. So that advanced beneficiary notice is designed to protect me as the patient, to know that you're not going to do that and that neither you nor I can bill that. So it's really designed, it's not a bad idea. It's an extra piece of paper, but it is designed to keep the Medicare patient from being taken advantage of.
And you're basically washing your hands of Medicare, saying, I'm not dealing with it. And you've got to tell the patient, by coming to me, you're not going to deal with it either. You're just coming. And we don't recommend you do that, by the way. We're going to get to our recommendation in a second. We're not saying do that. You can become a Medicare provider, and that's what we recommend. But what we actually recommend is you become a non-participating Medicare provider. If you become a Medicare provider, it does mean that you're going to have to go by their rules. It's going to mean that you got to go through the process of getting your provider. It's a pretty big application, and people that do it themselves routinely mess it up, and they have to do it over and over again and spend a lot of time. I've known it to take well over a year for people doing it themselves. You've got to use Medicare devices. You've got to do things by the Medicare guidelines, which are you have to have face-to-face with the physician. That whoever orders the sleep test has to have a face-to-face with that patient. In other words, that physician has to meet the patient and say, yeah, they need to have a sleep test and order a sleep test. And then if the patient is diagnosed with apnea, let's just jump down to moderate. If they have moderate apnea, Medicare says we'll pay you for a dental device right out of the gate here. We'll also pay for one with mild, but they have to have certain comorbidities, things such as having a stroke, hypertension, excessive daytime sleepiness. We can give you the details of the 7 comorbidities that they must have. If you want to contact us, we can write those out. But I just want to get to the big picture. They've got to have something besides a mild apnea, and they'll even pay for it with severe apnea, but the patient has to try CPAP first and fail that to where they're not wearing the CPAP. You have to document that they tried it, but they can't wear it. The prescription has to be signed by the physician, so you can't do this without that prescription. And they specifically state, Rich, that it's to be performed and billed by the dentist. It says by a dentist, not a physician, not anybody else. We were pretty excited when that came out, that finally Medicare did this a half dozen years ago or so.
And it's not unreasonable, Guy. When you look at this, they're managing our money. Every time you get a paycheck, or as an employer, you are contributing to money that through taxes that we pay to go into that Medicare system. And we have to be smart about how we spend that money. So don't shoot the messenger. Again, these are just the rules, and they're not that bad. So if you have a patient, you're screening a patient, and he's sitting in your chair snoring, while you're trying to clean his teeth, you should have a conversation with him about getting a sleep test. But if it's a Medicare patient, you got to go back and see your doctor, and they got to do this. So telemedicine does actually apply in some cases, Guy, if you're way out in the country or something like that. But so we've talked about remember that when you participate, you're accepting Medicare's fee when you do this. But the nice thing about how we do this and what we recommend is you can accept or not accept assignment on a case-by-case basis. So our recommendation is that you non-participate. You become a DME supplier, and then you non-participate on a case-by-case basis. So, for example, Guy, a little old lady came in my office. She was 94 years old. She didn't have any money. I participated in that particular case because she didn't have secondary insurance. So I'm going to take whatever Medicare allows when you do that. So remember that little box. It's box 27 on that CMS 1500 claim form. If you check accept or you check don't accept, you know how I remember this, Guy? If I check no, then I don't get the check. That's how I always remember that, because it's always kind of confusing, and this is a confusing part for patients. If you checked yes, then the check is going to come to me. If I check no, the check is going to come to the patient. So that's the best way that you can remember how to do that.
Just to back up, I want to make sure we made that clear. You need to apply to become a Medicare provider, but you become a non-participating Medicare provider. And then at that point, you can flip-flop basically between participating and non-participating on a case-by-case basis. So the little old lady that Rich talked about, he checks the accept assignment of benefits in box 27. On that case, it's just like he's a participating provider. If she had supplemental insurance, he'd get that $1,069 between the 2 checks sent to his office. If he doesn't check that because some other guy comes driving in and he can afford to pay Rich a little more, and Rich, his normal fee is above $1,069, Rich doesn't check that. He gives him his regular fee, whatever it is. Say it's $2,000 to make the math easy. The guy pays Rich. The $1,069 goes to the patient. The patient's out roughly $850 or so whatever the math turns out.
Yeah, whatever the math turns out to be. But the big advantage to non-participating, just so that everybody knows, is we can balance bill the patient the difference. That's the big thing that you have to see. Now, but the beauty of how we're doing this, that Guy is saying, is we can participate or non-participate on a case-by-case basis if we do that. We haven't opted out. We can now deal with Medicare patients, and if I get a really nasty guy that drives up in a Bugatti or something like that, and he doesn't want to pay $100, I just go, well, fine, here's my fee. This is what Medicare pays. This is what your part is. Yeah. But it makes the math easier. It gets a little more complicated when you have a secondary insurance, supplemental insurance to that, because now we got to try to figure out. So I think, Guy, as I'm thinking about this and I'm hearing you talk about it and doing it, remember the third party biller gets paid about 10% of what the check from the insurance company is. It's not your fee. If you charge $1,000 and insurance pays $500, you're gonna owe that third party biller about $50. And when I'm hearing you talk about all of the things that a third party biller does, Guy, I'm kind of going, man, I think it's worth it. I mean,
that's when we started out that way, but yeah.
Certainly in the beginning anyway, until you can get to the point where you can hire a full-time biller yourself doing this stuff. So remember the 855S, that is the form that either you or somebody in your office, or ideally you would hire somebody to do this.
How many pages is that?
When I did it, Guy, several years ago, it was 69 pages, I remember. Yeah. I don't know how many pages it is now, but this is what allows you to become a DME supplier, durable medical equipment supplier. So this is different from becoming a Medicare provider. So remember, there's a couple of moving parts here that
that's why it's a little complicated. But I want to emphasize one thing, because we kind of went full circle here. The reason we say to become a non-participating Medicare provider is, even in Florida, in most cases, you're leaving $1,069 on the table if you don't do that. That's $1,069 that patient deserves to have because of all the time they put in working in this country. And it's the right thing to do. And furthermore, if you only need $2,000 or whatever your fee is, they've already paid half of it for you. So there's really no reason to opt out, in my opinion. And it is a fair amount of paperwork. We'll talk in a little bit about our partner, Four Pillar Billing, and how they can help you do that for a fee, and they'll get that done. Typically, they're running in just barely over 3 months' time, so about 70 days it takes. If you give them everything they ask for in a timely fashion, they can get this done. So let's talk about commercial insurance before we go there, Rich. We're not going to spend quite as much time on this, but we'll go through it. I'm not going to spend a ton of time on in-network. When I teach across the country, we ask how many people are in network, and it's usually no one. We did have one person this weekend that was, but it's very rare. And we recommend that you try to do out-of-network billing, see how that goes. And if you find that you're not getting the reimbursement, then you can become in-network, because in-network's a lot of work. It took you years to get some of those contracts. You got to negotiate the fees. The fees are going to be lower. You got to try to get them up as high as you can. Advantage is that you do know what they're going to cover. You do have an agreement with them, but for the most part, most of you out there are going to be out of network. And when you're out of network, the big problem is you don't know how much they're going to pay. They won't tell me, they won't tell you, they won't tell the patient. So we don't know what their allowable amount is. But the good news is their allowable amounts are almost always higher than the in-network. Patient may have higher deductibles and some things like that, and higher percentages they pay, but the allowable amounts almost always higher. And if there isn't an in-network person in your area, and the patient doesn't have great out-of-network benefits, or they have no out-of-network benefits, you can apply to be in-network on a case-by-case basis. That's what we call giving gap coverage to that patient, and it's something for sure your third-party biller works hard for. It's worth paying them for, because that's kind of a pain to do, and they'll try to seek that out if that's the appropriate way to get the most money for your patient. So out of network, if you're in network, it's pretty simple. You know how much they're going to pay. You know what the math is. But for out of network, you've got to kind of make some decisions here and how you're going to handle it.
It's more challenging, Guy, because they won't tell us what they'll pay.
Right.
You know, I mean, and if you think about it, that makes sense. If I called you up, Guy, and I said, well, will you allow 2,000? You go, yeah. I'd go, I meant 3,000. Will you allow 3,000? No, we just keep going up until they said no, right? And that's what we charge. So it makes sense that they won't tell us, but it certainly makes it more complicated because we don't have that number now.
Right.
So we have to have that. So now we have to be creative about, because remember that patient's going to sit down and say, how much does it cost? What is my insurance going to cover? We got to have a plan for dealing with that.
Yeah, and one of the plans is back to what we talked about at the beginning. You want a fee-for-service practice. You don't care about building a bunch of medical referrals. You just come up with whatever fee you think you need to make you happy doing this. You look at your patient in the eye and say, this is a fair fee. It's X amount, and you pay me, and I don't mess with insurance. Or you could say, you pay me, I'll submit it to the insurance. You need to add a little bit to that fee because you're going to have to pay your third-party bill or something for that, and we'll see what kind of money we can get you back. We may get you back a few $100s, or we may get you back the whole amount, or we may get you back nothing. We don't know. That's fee for service. There's two kind of ways of doing that. Either way, basically the patient's paying you the full amount, either at the time of service or through payments. The other way is you tell the patient, you know what, I'm going to estimate how much they're going to pay. Your third-party billers do a lot of this. And they can say, yeah, we think they're going to, the allowable amount's usually in this range. And then you can kind of do the math based on their coverage, and you can say, all right, your portion's likely going to be this amount. And you can do that. And if it's not that amount, you can go back to that patient and try to get the money. That's what I call the fixed amount. But then the patient's not very happy, are they? Because they were perceiving it was going to be one, and now it's higher. I don't really like that. So the third way is that you take that risk, where you say, okay, I think they're going to be this amount, and I'm going to stick with a figure that the most is going to be for you. And if you do that and you take that risk, the only thing I can tell you is you need to raise what you bill, because at times you're going to take it on the chin, and you're not going to get what you think. So you got to make up for those times. And so you got to kind of make decisions there. And we do a whole nother webinar on out-of-network billing only. It's an hour long just on that subject, on how to make these decisions right here. So I know that we didn't totally define that, but I want you to understand that you have to think about it and try to either think about being up here or being down here. I think works better, and that's one of the reasons if you want to do a consultation, you say I want to talk to your billing service about helping me decide which is best for me. Just type in consultation, and Lisa, one of the team from our 4-pillar billing, will get on the phone and they'll explain that more thoroughly. And it's a decision you have to make as a whole office, because we have offices doing both of these systems, and it really has to be what's best for you. And we'll be happy to sit down and explain that better. We're just trying to give you the high level here today. What I also would say is that when it comes to how we bill this, you can bill a lot of codes. You can bill every time the patient comes in. You can do what we call evaluation and management codes. But if you're going to do that, you have to document. Right? Rich, you build those codes, do you? Or
most of them I don't. But again, you cross that line into medicine. So if you're going to bill for a 99203, it's very, very clear what you have to do and what you have to document in order to bill for that. Because if you don't document it and you don't do it, they're going to come back and audit you, and they're going to ask for their money back. So again, you can do a lot of that stuff. I think you until you really, really understand this to the point almost where you could get up here and teach it, you should be having somebody do your billing. I think a year's time, Guy, is probably reasonable to learn how to do this, to where if you want to bring it in-house, maybe you could, but I still don't think it's worth it at that point. But
right. And so until then, when it comes to which codes to bill, just bill the dental device, the E0486. Say, I'm going to see you for this many length of time. 3 months is what Medicare says. You can do that. You can say 6 months. You can say a year, whatever you want. I would probably go with 3 or 6 months. That's what this fee includes, all your appointments. And then it's simple. You look at how much time you think it's going to take you to see all those patients for those many appointments, which if we use our system, you don't spend that much time with them, because we do a lot through phone calls and so forth. But that's the fee, and keep it simple with just one fee. So those are the decisions that you need to make. Medicare to review. We want you to, our recommendation is that you consider all options. If you ask us what we think is best, is to become a non-participating Medicare provider, that you start with out of network, but then you've got to decide on which billing system you want. And how do you want to do it? We really feel you should use one of our third-party billers, because the less a patient has to pay, the more that they're going to
More
say yes
cases
to
to do.
Right.
That's brilliant, Guy. Did you come up with that on your own?
I'm just a genius, aren't I? I'm the only one in the world who knows that, right? Me and every used car salesman out there in the world.
it seems simple, Guy, but I think sometimes we lose track of that as the doctor. You know, we're thinking about what we do and how we do and all that other stuff. And I think sometimes you can lose track of that.
Yeah, and just to let you all know, that you can work with other third-party billers, but through DS3, and regardless of which one you work with, we have like 7 or 8, I think, now that we work with. I'm pretty sure it's up to 8. We make this simple. You just got to click buttons to do the instant eligibility check here. You just got to, it ensures that you have a sleep study. It prompts you, see the X here saying, oh, you can't submit a claim because we don't have the information. So it really prevents you from having to fax all this information back and forth to the insurance company, calling on the phone to the third-party billers, calling to the insurance company. You have DS3, you document all the things medically as we teach you how to do it. You click a button, it submits it to the third-party biller. They process the claim and communicate back with us throughout the process, and then you get paid, and it goes right into your DS3 software, the information that you need, and the checks actually come to you for this. We just streamline that process. Our preferred partners, a subsidiary of us called 4-Pillar Billing. I'm very proud to say that they do a fantastic job. I stand behind everything they do there. Our clients are very happy and getting paid for this. And so a lot of our DS3 members use 4-Pillar Billing, but you don't have to use 4-Pillar Billing if you just want to get your Medicare application filled out. They do dozens of these each month. They're down to, like I said, barely over 3 months. I think 7. I talked to Lisa, the head of the 4-Pillar Billing today. I think she said it was 71 days. I think it's the exact numbers what we're averaging. The normal fee is $14.95 if you're not a DS3 member. It's $9.95 if you are. And if you sign up this week, you want us to do your Medicare application, we'll take $100 off the applicable fee just this week. They're very busy, so don't ask us about it next week. But if you want to do that, type in Medicare, or just call us, or whatever you want to do. But type in Medicare, and we'll get in touch with you, and you can save $100. And 3 months from now, you can be billing Medicare. Most likely, if you do your part. I want to make sure we can't. Medicare's their own beast. It could take longer. It certainly will take longer if you don't get the stuff to 4-Pillar Billing that they need. But type in Medicare and we'll get you running. This will be you and your team and your patients for getting paid for saving people's lives. And getting paid for dental sleep can have big rewards. I mean, I went over this today, and it was like, really? I just got to do one of these a month to make about $20,000 more dollars in my practice, just south of that. We're not playing with the numbers. If you look at this, we're saying $2,500. Very reasonable amount to get back. $350 lab case fee, very reasonable. $200 to pay 4-Pillar Billing or another billing company, that's on the high end. You join DS3 for a year, and you're gonna get just south of $20,000 if you do one a month. If you do one a week, you're gonna be pushing 6 figures. Add it to your dental practice. For what else can you do in dentistry to do one procedure a week and take 4 weeks off a year for your vacation and add another 6 figures to your income? There's really nothing you can do that comes anywhere near that. And if you use the DS3 system, or you're interested in knowing about it, you type in consult, as we mentioned, and someone will talk to you about it. We can teach you how to go through each of these steps in under an hour of doctor time, 30 minutes to 45 minutes of doctor time to go through these steps that Rich went before. When I first met you, I was a mess. I was trying to figure this stuff out. You were already doing a lot more of this than me, but I was busy in my dental practice. How am I going to do this? You were, fishing most of the time, best I remember, but
Just a couple days a week. That's all, guys.
Yeah, but you had this, you were doing this, but man, how am I going to do it in my dental practice? That's what we do. We give you the plan for doing that, a system for making this go very smoothly. That's what DS3 is. Again, want to know more about that, just type in consultation and what's your best number, and we'll get a hold of you. Because I think a lot of people, when I was at Pank Institute this weekend, I didn't talk, trying not to be too commercial there, but what do you do? And I think everybody thinks it's just software. And it's not what we do. What we do is that's why we had the 360 there earlier. We help with bringing your team on board. How do you do this? How do you educate them through webinars, teach backs, and then yes, we teach them how to use the software through our coaching and so forth to get the teams on board and getting the right system. So that's how the software supports it, the whole thing. But it's not just here's the software and go. We help train you to get to the 4 pillars, which are screening, testing, treating, and billing. And we teach a lot of courses too. We do a 2-day course, 2-day hands-on course for $999. You get a dental device and a sleep test, and you can bring one of your team members. I don't know that anybody in the country does it for that. They certainly do as good a course. And I don't know, Jason put the slide in here, and Rich and I cringe every time that we'll offer $200 off anybody who wants to come. I'm teaching one in St. Louis on Friday and Saturday. We've got some in Houston, New York, Orlando coming up. I promise you'll get a ton out of this. And for $799, it's a pretty good deal.
I would say, Guy, if you're a dentist out there or staff and you think you might have sleep apnea, there's no cheaper way than to actually get tested and treated.
You get tested and a device. That's going to cost you more than the $799 anywhere you go. So, and you get a great bunch of education. And we usually even take you out to dinner on Friday night too. So, if it's a great time. I really enjoy teaching them. Rich teaches them too. It's just it's something that we when really. I'm
not fishing, of course.
Or seeing 10 new patients like you did today. So, but it's something that we feel we have really high marks. People come back very ready to begin on their dental sleep journey.
I think that's the biggest thing, Guy, is that you can't really learn how to do this in a 1-hour seminar.
No.
You can't learn how to do it in a 1-day course. You can't really learn how to do it in a 2-day course. But the difference with our 2-day course is you actually do a home sleep test on yourself. You get to read those sleep tests. You actually taking a bite. You're doing AM aligners, you're delivering dental devices and stuff like that. So I think all of the things that we think are easy now, Guy, because we've done them, dentists are hesitant to do that. And that's the biggest thing that kind of gets you over that hump so that you feel comfortable next week having those conversations with patients and actually getting started doing this.
Yep, I agree, and I can say I can give you my personal promise that you'll be happy you came if you want to learn about dental sleep. The course is very, very practical. And then talking about practical, Jason Tierney, who's our head here, he's the right-hand man, the COO of our company. He spearheaded this thing, and man, what a difference it's made. This will be our 3rd year of the North American Dental Sleep Medicine Symposium next year. And I heard from the people at the Pank Institute this week just telling me how wonderful that was. We had such good speakers, and I had to hand it to Jason here. He's topped them again with the speakers coming this year. It's in February. It's in Clearwater, Florida. The rooms are $250 a night, which is about pushing half of what they normally cost. Those will sell out. And I promise you the symposium the rooms I promise will sell out. And I'm fairly certain the symposium will sell out because we were close to capacity this year, and we've already got way more signed up for next year than we did this time last year. And we have even just some great speakers coming from Jameson Spencer to Mark Fowler. There's that Rich Drake guy down there too. He's going to talk, and I'll talk too. So put it on your calendars, but don't wait till the last minute because this will be our 3rd year. Both of the first.
We'll sell out. The first 2 sold out, and this one will too. We're confident.
And everybody's calling and saying, "Why can't I get a room? Why can't I get in?" And you don't want to do that. Your team will love it too. Don't forget, I'm excited. We say we got the night off, although I'm going to likely listen to Mark Fowler and Jason. Jason's just a world of knowledge himself. And then Jason knows a ton about marketing too, so he helps us out with our marketing. This is going to be really kind of some very fresh material, because we've done this billing webinars before, because it's a last for we do it once or twice a year, but this is a whole new subject. Digital marketing, man, it's changing so fast that we can't keep up. You can't just think I'm going to do my own website. They're going to talk about other marketing as well, I think. But I know that Mark Fowler's an expert in digital marketing, how you get your website up, how you get your Facebook presence, and all those things that, man, I'm starting to feel old, because I don't know how to do it myself. You got to hire the experts. I think that's going to be a phenomenal, great information there. And let's see, I can't see what that says.
Yeah, our team, our insurance team mostly is the ones who've been on here answering questions tonight, and I think there's been about 200, Guy.
Wow.
So there's been quite a few, and it looks like we've covered most all of that stuff. So
we got them all. Are we good? Let's see. I think I got one more slide here and put that up for contact information. There it is. So have they? Wow, y'all. This is how efficient our 4-pillar billing insurance team is. They're just punching out the answers here.
I don't see anything there, the guy, that's not covered. So hopefully you guys, as you're listening, have been looking through these questions, because we simply cannot cover all of the information that we need to cover in an hour. So there were a lot of good questions asked, Guy, and I think we answered. Our team did a good job of answering all of those. So.
Yeah, and again, if we didn't get to something, we like to give back, and we're happy to take the time. The 4-pillar billing team, we happy to answer a question or two. We'll be happy to answer. So you just type in consult or 4-pillar billing consult even, or something like that, and we'll set up a time to talk to you about what your issues are. We'll answer them for you. And of course, we can tell you how we can help all the 10,000 other questions that you don't even know to ask right now as well. So I think it's been great, Rich. I got to get on a plane tomorrow and fly, and it's been a long week. So here I sit in my hotel room, in case you're wondering about the very drab background. But looking forward to hearing Jason's and Mark Fowler in a couple of weeks. Hope everyone has a great week, and get out there and make some dental devices and help save your patients from snoring, and help their airways, and save their marriages, and live long and prosper, as they would say in Star Trek. I've been a long week. I better be quiet now. So
that's
we
right.
Done, Rich?
I think so. I just want to make sure that the questions were all being answered and all that stuff. You guys will be getting your CE within the next couple of days. Thank you for the compliments, everybody. We appreciate that. We enjoy helping dentists to become more competent, and certainly more confident, and we certainly like to get paid for what we do, and that's why this particular one is so popular. So thanks, Guy, for putting that together. You did a great job as always, and we appreciate everybody spending part of your evening with us. So have a good evening and a great week, and get out there and start doing some of this.
All right, sounds good. Thank you all. Have a good night. Bye-bye.